So this is sponsored by with an educational grant from BSV, bringing life to life. And welcome all to the first program of the evening, Convergence, the Endometriosis Awareness Month, IFS BSV webinar series. And I welcome Dr. Neena Malhotra, MD DNB FRCOG, Professor ART Center, Department of Obs and Gynecology, All India Institute of Medical Sciences, New Delhi. Training in Art, Assisted Reproduction Unit, Aberdeen, Scotland. Yale Fertility Center, Yale Medical School, USA. Fellowships, Commonwealth, Fellow Boy Scout, Fellow DST, Sir Malcolm Black Fellowship 2015, RCOG London, Overseas Fund 2010, 2017, RCOG London. Neena ma'am has a very good clinical interest in reproductive surgery, endometriosis, reach interest, endometriosis, genital tuberculosis, implantation failure. She is a well-known figure and I am handing over the dice to her. So Neena ma'am, all over to you.
Yeah, thank you, Bruno. And thank you, Science Integra, and of course, Bharat Serum Vaccines for giving us this opportunity. We know that March is the month of endometriosis awareness. As clinicians, doctors, seeing patients, we are aware of the disease, yet we are still naive about this very enigmatic disease, which presents with many facets, ranging from pain during periods, during ovulation, during sex, and of course, chronic pelvic pain besides infertility. We know 1 in 10 women will be suffering from endometriosis, and we get these figures, approximately 200 million women across the globe suffer this problem. So, while we know that endometriosis is a huge burden, besides chronic pelvic pain, it carries not just an individual but a societal cost. It comes at a big cost. And therefore, to deliberate on the important aspect of infertility, we have none other than a brilliant panel which is being moderated by Dr. Kuldeep Jain and Dr. Sarveen Koman. So let me take the opportunity to introduce the two moderators. Dr. Kuldeep Jain is a well-known figure in the field of infertility and ERT. He is the founder secretary and the past president of our society, a passionate laparoscopic surgeon and a consultant par excellence. He is the director of the Kuldeep Jain IVF Center, and he holds to his credit many chairs, including the International Exchange Committee. He's been the editor, and he is the editor-in-chief of the Fertility Science Research, which is his baby. I think if I go on reading, we will probably go on with his many, many achievements. The second moderator on the panel is Dr. Sarveen Koman, who is the director and head of the IVF and Reproductive Medicine Services at the Max Multi-Speciality Hospital, Panchsheel Saket, Patparganj, including Delhi and Gurgaon. She is a professor at the School of Health Sciences, Ulster University. She has to her credit many books whom she's authored and has over 75 publications. She's currently the treasurer of the society, and besides this has numerous awards, including the Foxy North UA Award and the Distinguished Service Award. So I'd hand over to Dr. Sarveen and Dr. Kuldeep to go ahead with this interesting panel with fascinating, panelists on their team. So over to you, Kuldeep sir and Dr. Sarveen.
Thank you, Dr. Neena. It is really wonderful to connect on this evening on this very interesting subject that is endometriosis. As you know, that endometriosis is a disease of debate and controversy. So what we are going to spend in next 1 hour, we will try to start with the controversies and debate and try to find out in the end some solution which our panelists they are going to share their experience as well as something from literature, what are the evidences, and then we will try to sort out a few of the dilemmas associated with endometriosis, which will be really helpful to all practitioners. Today evening, I am joined with Dr. Sarveen Koman, who will be moderating with me, and we are having a who's who of Indian scenario in reproductive medicine. They are all stalwarts as our panelists. So I am very sure that next 1 hour is going to be very exciting. I will like to introduce my panel, starting with I welcome Dr. Sonia. She is a well-known figure in Delhi, in India, as well as outside India. She is past president of Indian Fertility Society and director of South Fertility IVF in Delhi. She has been a very renowned expert in infertility for last so many years. He has been practicing almost now 30 years plus. She was chair of Infertility Committee for C. She has again held a lot of positions. And I welcome Dr. Sonia for this interesting panel. Next in line is Dr. Pratap. He is again a very well-known figure, a master in teaching. She is heading Department of Reproductive Medicine Surgery at Kasturba Medical College, Manipal. He has held several positions like National Vice President of FOXI 1999, Inspector, Examiner, Advisor, National Board of Examination. He was appointed editorial committee of the several journals, President, Karnataka State Chapter of FOXI. And beside this, he is a very well-known teacher and thorough gentleman. So I welcome Dr. Pratap. Welcome to this panel. Next in line is Smith Patki. He is again a very well-known figure. Everybody is knowing. He is a medical director, Fertility Associate, Mumbai, honorary associate professor at Somaya Medical College, consultant at Khar Hinduja and Surya Hospital. He has more than 35 publications in national and international journals, and he has been practicing reproductive medicine again for 30 years plus. So you see that all our panelists, they are having very vast experience as far as the infertility, IVF and endometriosis is concerned. So we are going to have a very renowned, very interesting panel. Next, panelist, I would like to invite Dr. Roya. Dr. Roya, has she joined? Can I have CV of Dr. Roya?
Please, here.
Yeah, so Dr. Roya Rajati is again a very well-known figure in South as well as a very active member of Indian Fertility Society. She is the secretary of the chapter at Hyderabad, director MHRT Hospital, Banjara Hills, Hyderabad. She is associated with a lot of societies, and I know her. She has been very active in all our activities of Indian Fertility Society. So welcome, Dr. Roya. Next is a younger part of our panelist, Dr. Kunjumuddin. He is again a very energetic. Everybody has seen him during Fertivision, which was held at Cochin, very successful conference, having more than 23 years of experience, so not that young, but yes, amongst our panelists, he is the youngest. Again, founder member, founder managing director of ARMC IVF network at Kerala, Tamil Nadu, chief consultant at Perinthamalana, visiting laparoscopic surgeon at Dubai. He is very busy, and he is a very good friend of mine. So welcome Kunjumuddin to this panel. So with this, as you have seen that our panel is very, very heavy, and I am very sure that whatever questions are there in panel, we are having a case-based scenario. These are real time clinical scenario, and all cases are having some dilemma, some controversies. All cases are open to all panelists, and I will request my panelists, if somebody wants to give any comment in between, they can raise their finger, so there is no overlap, and I or Dr. Surveen will invite them to comment on endometriosis. As I have already highlighted that it is a disease of debate and controversy. There are many dilemmas, especially when it comes to etiopathogenesis. Coming to diagnostic, again there are a lot of dilemmas, and everyone, including my panelists, they will be having a different opinion when we as we go ahead. So that will be really interesting, and we will try to reach to a conclusion. And then when it comes to treatment and follow up, again there are a lot of controversy. We are having a lot of guidelines coming up from surgical societies and infertility societies, but when it comes to practice, our experience also counts, and there where we are going to discuss what everybody is practicing and how they are managing their cases. Uh, when we talk of endometriosis, we know that it is a disease of puberty, but usually diagnosed during the reproductive life when the patient becomes infertile. And even before that, the pain is the problem in adolescent, and they are diagnosed not before 7 to 8 years from starting their symptoms. So that is the diagnostic dilemma in adolescent endometriosis. It is a chronic disease. Infertility, there is always a lot of problems. So with this background, this is our first case. This is a 38-year-old woman having one child of 10-year-old, and she is trying to conceive for last 8 years. So she is a case of secondary infertility since 10 years. We find that they are bilateral adnexal tenderness, and there is fullness in right fornices. Uterus is normal with restricted mobility. So with this finding, it is but natural that all my panelists will agree that a ultrasound will be advised to make the diagnosis. Suspected diagnosis was in this case a endometrioma or endometriosis. Maybe
Not audible, sir. Is sir
I think
audible? Yeah. I can't hear anything.
None of us can. I think he lost connection. Survi,
yeah, I think Gurvin take over.
unmute.
You'll have to stop screen sharing. हाँ सर आपका कनेक्शन नहीं आ रहा है. ओके अच्छा ठीक है. Yeah, I'm screen sharing now.
Please make it slideshow. Slideshow, please.
Yeah.
Yeah. Okay.
Okay, so I think the case is in front of you. Infertility, secondary infertility, 8 years. History of dysmenorrhea, dyspareunia, constipation, pain during passing stool and urine, and chronic pelvic pain. On examination, bilateral adnexal tenderness, fullness in the right fornix, induration in the posterior fornix with tenderness, and uterus is normal with restricted mobility. Ultrasound is showing this cyst on the right side. How will you proceed to investigate her? I think Dr. Kuldeep had put this question to Dr. Sonia. So what are the investigations further, and how, which ones would be the best to
thank you so much for this. Thank you very much for inviting me for this very interesting panel. First of all, thank you, Dr. Kuldeep, and of course, thank you, IFS. So, if we didn't have the ultrasound, and if it was those days when I was doing my post-graduation, we would have said and opened her up as pelvic inflammation, the way she's presented. But of course, with this history and with this kind of a picture on ultrasound, yes, it is endometriosis. However, the role of the TVS is basically two. It is essentially now what we need to define is what is the extent of endometriosis, given that she had dysmenorrhea even before she started presenting with other things 10 years ago, wherein we presume that it may have just started, or it may be just a spasmodic dysmenorrhea for all we know, but of course she's had a child. But it seems to be progressive. So the extent of endometriosis, and if we have to do a surgery, what are we looking at? So that is what we need to define when we are talking about the investigations. And for that, of course, the role of ultrasound, as you had projected in your slide, is immense, because it does define the various types of endometriosis that we have. And of course, the MRI is essentially to define or delineate the extent of endometriosis in the adjoining organs, that is in the renal tract as well as the gut, etc., especially with the reference to the deep infiltrating endometriosis, which this patient may be having because she's having dyspareunia. So basically used for that, and to ultimately define our surgery, type of surgery and extent of surgery. That is how I would proceed with this patient.
So this particular patient, you would definitely get an MRI done.
Yes, I would.
Right.
Yes.
Dr. Pratap, what is your take on this as far as the MRI is concerned? Do you always go for MRI to confirm the diagnosis? What is actually you are looking when you are advising MRI? What is your aim?
Yeah, thank you so much. I would agree with Sonia that if it's necessary, we will do, but I don't routinely do MRI for my operations unless we have some doubt, because the ultrasound can pick up where is the lesion except the deep infiltrating one. I think because she only has dysmenorrhea, she doesn't have dyspareunia.
Yes, she has.
The thought, I think ultrasound is good enough, but I would do anti-Mullerian hormone in her and assess the ovarian reserve before I take up for surgery. But since she has a lot of pain, we have to consider surgery if required. But I think if it's a fertility is an issue and AMH is already low, I think probably I would take a decision on IVF directly, since the ovarian cyst is quite small.
We are actually focusing in this case about the diagnostic modality. Leave aside the management. When we talk of diagnosis, the ultrasound is as both of you highlighted that ultrasound is the primary diagnosis, and most of the time we are able to manage the cases on the basis of a good transvaginal ultrasound. But whenever you are having a doubt, like Dr. Pratap and Dr. Sonia has highlighted, and especially in this patient is having deep dyspareunia also. So MRI may be justified, but not routinely. Dr. Amit, are you having any difference of opinion as far as the MRI is concerned?
Yes.
And any other investigation apart from MRI, like trust, how much the trust is being practiced in endometriosis?
I think
especially in this type of cases when you compare.
yeah, I think a good transvaginal scan done by ourselves, we will be able to pick up a lot of things. I don't think MRI is routinely necessary. She's 38 years old. Her AMH should have already started dropping down, and with endometriosis of long-standing duration, her fertility must be on the lower side. And since she's having so much of pain, I think I will treat her pain more than the fertility first. And I think that can be done only based on a good transvaginal scan.
Okay, so MRI and TRUS, they are conditional investigation, not routinely done in all cases. That is what you want to say?
Correct, correct.
Yeah, so I think all our panelists, they have highlighted that there is a role of MRI and TRUS, but not in all cases. But you should not withhold the investigation like MRI and TRUS when you are suspecting a deep infiltration, because there is a limited sensitivity of transvaginal sonography as far as the deep infiltration is concerned. So their MRI and TRUS, they both are very specific and having a high sensitivity. What about the biomarker? Is anybody is doing any biomarker in such type of cases? Anyone can take. Dr. Roya, are you doing any
Yes,
biomarker when you are
yes,
having a case of endometriosis?
yes, sir. It is actually, we have a research project grant from ICMR. In all the cases who are undergoing laparoscopy, we do the biomarker, and with the confirmation by laparoscopy that she has an endometriosis, then the serum and then the peritoneal fluid and the urine will be taken for doing certain biomarker, like no mRNA biomarker, the molecular biomarker, mitochondrial biomarker, and protein biomarker, CA125, all those things we do. And just I presented our paper in our ISSRF. There are almost
but are you
papers we have
doing
already published.
are you using apart from research setting, are they recommended or you are doing routinely
It's
the
not in it's not in the
CA125?
market. It's not in the market, sir. It is still at the research level. Is not only single marker. Is a combination of panel of the markers. It's CA125 protein markers plus mRNA marker, polymorphism, microRNA, and mitochondrial. These are the panels of the biomarker, which is still on the research, which is increasing the specificity and also the accuracy of the diagnostic marker, where we are doing the comparative study between the non-invasive marker and laparoscopy, because laparoscopy is a gold standard. And then, but there are certain cases that they need repeated operative procedure. So these are the cases where they can be benefited in future from these non-invasive procedure that they test panels of the biomarker.
So
These are the lesser.
any comment from other panelists? Dr. Amit, what is your take on CA125? Because that is one biomarker which is done routinely in endometriosis by many of the consultants. So I will like to give at the end of this discussion, I will like to have a clear-cut answer whether CA125 is helpful or
It's not single panel. It should be a combination.
It CA125 basically has got prognostic values to monitor and see on follow-up to see this patient. In clinical practice, I would not do CA125 once I know that it is endometriosis.
Yes.
However, if I suspect that there is maybe I suspect cancer in this patient, then I would do all the tumor markers for this patient. But rarely would you get a patient with endometrioid carcinoma. So I would stick to doing only a transvaginal scan. I would, if she's come for infertility, I would do a AMH before doing any surgical procedure. and then treat her surgically, especially in this patient because she is symptomatic.
Dr. Pratap?
Yeah, I don't do routine biomarkers in my clinical practice. As Amit said, that if there are recurrences of endometriosis, I would suspect some problem. And I also feel it's just a prognostic point. Research-wise, I think it's good to research. Find out tomorrow the answer may come out, but at the moment, I am not recommending.
Punjavadi.
Yeah, CA 125, actually, it is not
Dr.
recommended.
Punjabuddin, what is your...
Can I speak? Yeah, CA 125 is recommended
please,
by
please, go ahead.
the few of the literatures which have come later. So in deep infiltrating endometriosis, it is CA 125 is recommended to do to have the better prognosis, and it will be very much elevated in deep infiltrating endometriosis. So it has role only when we suspect deep infiltrating endometriosis.
Yeah, so this is the guidelines of SRA regarding the biomarker. It is not routinely recommended. And if you are doing a CA 125, that is for prognostication, not for the diagnosis as such in endometriosis. That has been the consensus that when you want to diagnose endometriosis, CA 125 does not have any role. But when you want to prognosticate during your course of treatment, it might have a role in prognostication. So, as far as the CA 125 is concerned, it is having a big question mark, and in routine practice, it should not be done. What about the laparoscopy? Leave aside this case. Whenever a patient is showing a mass having clinical features of endometrioma, do you always go for laparoscopy for diagnosis or confirmation, or there are certain indications where you put the laparoscope to confirm the diagnosis of endometriosis? Dr. Sonia, what is your practice?
It is not the primary investigation, or I would say the primary modality to diagnose it. It should always be done whenever we are thinking in our mind that we have to treat it, So basically, it should be more of a therapeutic rather than just being a diagnostic. But of course, yes, because many a times you may have a negative laparoscopy also, and then especially in a younger patient, maybe not in this patient because she has findings as well. But in a younger patient, or say an adolescent, where you can get into a problem with dysmenorrhea and then you do a laparoscopy and you find nothing. So therefore, it should be restricted, and it should be only done when there is an indication to do some therapeutic intervention along with the laparoscopy. That is how I do it.
But for diagnosis, leave aside the intervention. What are the conditions where you will like to put a laparoscope to make the diagnosis confirmatory?
If you are very uncertain about the diagnosis and your primary treatment has failed, suppose the patient had pain as in this patient, and you have treated her pain with the basic things like NSAIDs, etc., and they have failed. Suppose she had no endometrioma, she just has pain, and you are suspecting endometriosis, and you don't know. You have given her actually treatment, and that is also not effective. In that case, yes, you would like to put in a scope and see what is happening inside.
Yeah, so especially those cases which are
uncertain,
having a diagnostic dilemma on laparoscopy, there is certainly a place of laparoscopy. But if you are very sure by your ultrasound finding, and you are not finding anything contradictory, then usually, though it is gold standard, it has been said that laparoscopy is the gold standard and you have to do histopathology and all that. But in routine practice, I don't think any of our panelists, they are putting a laparoscope to make the diagnosis until unless there is some doubt.
Age of the patient also.
What I will like.
Age of the patient. Yes? Dr. Kuldeep, age of the patient, I think we have to also consider. when
what
we
do
are
you
making
mean?
it.
What do you mean by age of the patient?
No,
Like, can you highlight?
yeah, there are factors like pain of the patient, desire for the childbearing, and also if she is 30 or 32 years or near end of the reproductive age, I think the role of laparoscopy is not always intervention, but then as a diagnostic, so that then the plan will be more clear.
Yeah. Any difference of opinion from our panelists?
There
on
have
this
been
point?
papers, and that is also a known thing, that in cases of unexplained infertility, you do put in a scope, to see whether you can explain the unexplained. And I think Dr. Rosa is meaning something like that, especially if the patient is of
Yes.
an older age and she has come to you as a case of unexplained infertility, you would want to put in a scope. Papers are generally, the Indian papers are quoting an incidence of about 33 to 36% of patients turning out to be about. The Gangaram paper from Abbas unit states a 33% endometriosis rate in cases of unexplained infertility. So I think that we have to take into account.
So there is a place of laparoscopy in suspected cases of endometriosis, and when you are not finding any.
But these are purely unexplained, not suspected, Dr. Kuldeep.
Yeah. Dr. Sulbin.
Stupat.
Dr. Sulbin, can you move the slide and go on the next question?
Yeah, can you hear me?
Yes.
Okay. Case 2. This is Mrs. OL, 32 years old, married for 8 years, male factors normal. Laparoscopy done 15 days back, which showed a small peritoneal endometritic implant in the POD, which were coagulated. Tubes are patent and normal. No adhesions. AMH is 2.2. She is keen to conceive and has been trying for 2 years. What will be your option of treatment? Expectant, IUI, IVF? Are the results of IUI different from other patients without endometriosis? The patient puts a question on whether stimulation would cause recurrence. What would your answer be? What drugs would you use to stimulate? Clomiphene, letrozole, gonadotropins? How many IUIs before IVF? It's a pleasure to have everybody on board and such experienced panelists. I would be putting some evidence, and I would love it if it is contradicted by your experience or collaborated by your experience. So, Dr. Sonia, what would be your option of treatment? Expectant, IUI, or IVF?
Surveen, can you just go back on the case 1 second? Sorry.
Yeah.
Just go back on the case. Yeah. She's 32 years and she's been married for 8 years and she's been trying for the last 2 years. AMH is not bad. So basically, yes, we could give her, and she's just minimal endometriosis. So basically, I would want to do an IUI rather than expectant management. There's no sense doing expectant because she's already been trying for such a long time. So even though you've cleared the endometriosis, her chances of having success would be better with an IUI.
So anyone will go for expectant management. Anyone will go for expectant management in the panel.
No, sir.
No.
There is no.
So the message is very clear.
Anyone
is very clear. She needed treatment, sir.
Yes, she needs.
Anyone would go only for ovulation induction without IUI?
No.
So we are absolutely clear. We are doing IUI in this patient.
Yes.
Before, sir.
So does stimulation cause recurrence? Dr. Pratap, any evidence?
Yeah, I don't think stimulation would cause recurrence because we're going to have a short time, maybe a couple of times of IUI and then decide what to do. None of these procedures will increase the incidence of endometriosis. And of course, if you don't do anything for a long time, it may come back. That's why I think most of us are actively kind of procedures, and that answer is not increasing the incidence of endometriosis.
In anybody's practice, have they found an increase of endometriosis while stimulating? Anyone, Amit?
No, I don't think. I agree with Dr. Pratap that it doesn't really increase. You're going to do a few cycles. I may be a little controversial in saying that I would not prefer to give clomiphene, but may go on to gonadotropin.
Yes, I do. Same here.
So, is there anybody who will give clomiphene IUI or letrozole IUI?
No.
Roya?
No.
Yeah, we will not give letrozole alone.
We gave gonadotropin before cycle of IUI.
So in
I
all,
think Kunju, I think you would give letrozole.
Yeah, we generally prefer letrozole plus gonadotropin cycles for IUIs in these patients.
I only find that when you give oral ovulagens to these patients with history of endometriosis, they quite often have luteinized unruptured follicle. And that is why I sometimes prefer going only for gonadotropin. Now, although this patient has got AMH of 2.2, which is not really good, but not really, I mean, not bad, but not really good either. Considering that she's married for 8 years, but has been trying only for 2 years, I would talk to her, but I would be inclined to counsel her for gonadotropin.
Gonadotropin.
Okay, since you mentioned LUF, there is one question I'm putting offhand that after how many cycles of LUF you say, okay, now let's go for IVF. I want everybody's take on it. 1, 2, 3. Dr. Sonia, starting with you.
With 1 cycle.
Dr.
Look
Pratap?
at her history, 8 years of infertility.
Yes.
Yeah, I don't think I would wait for too long. I agree with this, Sonia, that I think couple of months I would see and then decide on the further treatment.
Amit?
Yeah, so now LUF in my mind can be because of 3 things. Sometimes it can be because of premature LH surge. So maybe in the next cycle I will do her LH, give her antagon and try another cycle of IUI. But as Dr. Sonia said that, if it's a LUF, it is either premature LH surge or undiagnosed endometriosis or oral ovulation. If I've ruled out all these 3, then I think it is ideal.
Roya, what about
you? I agree with Sonia Madam. Only 1 cycle, and what Amit says is very correct that we have to look at the aspect of 1 or 2 cycles, not more than that, and we have to also try at least LH antagonist so that to prevent the LH surge. And once we don't get, and again we get a LUF, then I think we have to embark on the ART and IVF.
Kunju?
Yeah, of course, with this low AMH, mild endometriosis, and long period of infertility, age more than 30 years, we should not wait for more than 1 cycle with LUF, and that holds true even with IUI cycle.
Now, this is something I want your experience. Do you find that they are low as far as success rates are concerned with IUIs? Or you feel that they're the same as unexplained infertility?
No, it is less. It is definitely clinical pregnancy rate is less.
Amit, what about you? Do you feel that?
I don't know, but I think unexplained infertility, the success in IUI is the lowest.
Yes, even I.
So I go a little reverse to what your graph is showing. I think.
Even I would say that actually the problem is, Surveen, that we get very few cases of endometriosis or unexplained, which we are not treating with IVF. We are generally putting them through IVF all the time rather than doing IUIs. So that is why we may not be agreeing with this. Yeah, we may not be agreeing with this very much. I feel like Amit says, I also feel unexplained is very difficult as compared to endometriosis.
In fact, why the laparoscopy was done for this case?
Yeah.
Why was it done?
Yeah.
Well, it was already done when she came. I think n number of gynecologists are sitting to do a laparoscopy on an infertility patient.
True.
We are questioning that every day, that why was it done or why was it not done?
Yeah, maybe.
So number of trials.
Maybe because there was no other findings. She was having a prolonged infertility, and before directly going for IVF, laparoscopy becomes one of the indication in such type of cases. If you find again explaining the unexplained is the logic behind putting a laparoscope. And if, like in this case, there was a mild and moderate, very mild endometriosis, and there's a lot of literature which says that after correction of mild endometriosis, you can improve the chances of IUI when you combine just after surgery. So that is the logic. That is the logic behind putting a laparoscope, correcting the subtle defects, and then going for IUI. You will certainly have a better prognosis in these patients.
See, the endometriosis, can I just butt in for a minute? And endometriosis also causes some amount of inflammation inside. So when you actually burn the endometriosis, you will reduce the inflammatory, the macrophages. And as Dr. Kuldeep has rightly said, even if it is mild endometriosis you treat, you definitely get a better outcome even in IUI.
In fact, they've seen that the inflammation you were talking about, even there are higher incidence of endometritis, like picture in the endometrium.
Correct.
And immune modulators are known to kind of settle things in endometriosis. So
Again,
how much is too much? Where will you stop? Dr. Sonia, where will you stop?
Sonia has already said one cycle.
I've already said one cycle.
One cycle was the luteinized unruptured. IUI with a proper rupture of follicle, is it one cycle, 2, 3? Where are we going to stop?
Surveen, I think, the first cycle is going to tell you whether she's going to conceive or not. Generally, that is what happens when you are doing a stimulation in an IVF center. You really understand what is the physiology of these patients, and therefore you don't want to give them too many trials. So, since you are asking, and it's, I would not go up to 4 cycles where he's claiming a 95% rate. I would stop at 3, definitely 3, not more than that. Because it's gonadotrophin cycles. At the end of it, you have to think of the cost to the patient, and finally you are going on to IVF. It's going to be a hell of a cost to them. So I would certainly not go beyond 3 cycles.
Anybody would not go beyond 2? 1?
No, only one.
One is basically
the data which are showing is
beginning.
the normal reserve unexplained mild male factor, but the case what we are discussing is totally different.
Yeah.
So I think 2 to 3 cycles is something that I would do. We all must understand, I think the message to the viewers is that an IUI cycle has success of only 22 to 25%. That is also something that we must.
Yeah, so what is written here in this paper is the cumulative success rate, but even that I feel is too much. I don't think we can.
Can I say something, Surveen? What you read in the slide, it says 88% of pregnancies.
Of pregnancies, yeah. This is of pregnancies.
Of the pregnancy. That means I think.
So your first 3 cycles give you 88% pregnancy, and
No. Yeah, he's absolutely right, Dr. Pratap.
88% pregnancies occur in the first 3 cycles, so you can stop after that. Maximum is another 7% which occur after that. So what I have seen is that after 2 cycles, the patient says, "Doctor, please IVF kar do."
Yes, you're right.
Not go on for too many times. It's okay, but two IUI cycle is quite good enough.
So I think the message is very clear. Not too many cycles post surgery in such type of patients. Though there is a difference of opinion amongst our panelists, somebody is saying 1, somebody is saying 2, somebody is going up to 3, but nobody has said beyond 3. So that is one consensus. If you look on the literature and X-ray guidelines also, they say that up to 3 cycles can be tried in these patients, not beyond 3. So that is the consensus as well as the message to the audience that in these patients you should analyze every cycle why you are failing, and if you feel that the cycle was good, only thing because of the low fecundity of IUI, you can plan another cycle of IUI. So that is how you have to be individualized as far as the number of cycles are concerned.
I also feel that, this study should have given how much 2 cycles gives you and how much 1 cycle gives you. And maybe then we can make up our mind.
Yes.
Correct.
Yeah.
No, I don't think we need this study to make up our minds. We know our minds.
Absolutely.
Yeah, so here basically the experience over the period, accumulated over the period, is coming very much coming into play when we are finding so much difference of opinion as far as the number of IUI cycles are concerned. But even if you consider the evidence, it is not beyond 3 cycles. So that is the message.
Okay.
Coming on to, yeah.
The third
So
question. Third case.
so we are moving on this third question. This is 34-year lady married for since years. So there is a little twist here. She is having 8 centimeter endometrioma, 4 years married life, trying to conceive for last 4 years. Semen is normal, AMH is normal. What is Kunjumuddin? I am coming to you. How will you manage this case? Whether you will go for medical management or IUI or doing laparoscopy and then IUI or straightway IVF?
Yeah, there is no question of medical management in endometriosis if the patient really wants to conceive. And here the bottom line is that her age is 34 years and she has the AMH is a little bit on the lower side and the endometrioma is pretty bigger. It is almost 8 centimeter size. So as mentioned in this slide, which I already told, that preoperative medical therapy, there is no role if it is for infertility treatment.
No, so
And
you are planning.
comes to the
You are planning surgery or IVF?
No, sir. Here in my the practice, I usually plan for IVF only to start with, unless otherwise this 8 centimeter endometrioma is obstructing the retrieval of oocytes. If it is obstructing the retrieval of oocytes, then definitely I'll go for ovarian cystectomy.
So here is the point of debate. How many people, Dr. Pratap, you are for laparoscopy in this case or IVF straightway?
Yeah. I think that because the size is 8 centimeters and her evaluated AMH of 3.2, I think surgery is better to do so that we get, because whenever you leave behind a lot of endometriotic tissue there, the oxidative stress is very high, and the IVF, the results of fertilizations are definitely on the lower side. So I would probably in this case, because the size is 8 centimeters, I would remove and then plan 5 years. Yes.
So you are for laparoscopy. Dr. Amit, what is your take on this?
I think
laparoscopy or IVF?
No, I think she needs a scopy. It is very large, 8 centimeters, and she's been trying for all the last 4 years. So she needs a laparoscopy any which ways to check for tubal patency, to get this excision of this cyst, and then to go ahead.
Dr. Roya, what is your opinion?
Laparoscopy, because of this size of this cyst is big, 8 centimeter. It is laparoscopy.
Okay, so consensus is laparoscopy in this case. So you have decided laparoscopy. How many of you will go for pre-operative medical treatment before laparoscopy?
No.
No.
Anyone is using any pre-operative medical management?
No, sir.
No. So answer is no. I think very, very clear messages are coming from this case. There is a role of laparoscopy in such type of cases because AMH is quite good and endometrioma is very huge. So there is a case for laparoscopy. Second, no preoperative medical management in this case. Now, third thing which I would like to ask, whenever you are putting a scope in such type of cases, what are your main concern, and how you are counseling your patient regarding the problems or any concerns which you are having? Kunjumuddin, again starting with you.
Here the main concern for surgery in a patient with a 3.2 AMH is, again, our surgery may reduce the AMH further. It can harm the ovaries further if the surgical techniques are not perfect. So we have to counsel the patient because we are doing the surgery because it is so large.
No, there is the patient has come. patient has come to you, Kunjubuddin, that you are a perfect surgeon. So that is not taken into account. You are a good surgeon, but still there are few concerns like
however good,
yes.
however good, there is a chance of reducing the AMH immediately after the surgery. So that we have to counsel the patient, because very often these patients go and check AMH immediately in the post-operative period, maybe 2 weeks or 1 week later. So they should not come back to us that the AMH is less at that point. And we have to advise the patient the gold period for conception immediately following the surgery, and we should not suppress anything with medicines following the surgery.
Dr. Amit, yeah.
I think concerns at the time of surgery that it is a long-standing large endometrioma. So we have to be careful about it being adherent to various the structures.
Yes,
so that is something that I would like to counsel the patient about.
Yes, Dr. Pratap.
Yeah, I think meticulous surgery, as you said, is absolutely needed, and very carefully remove the cyst. And usually, in fact, I've published my own data. Well done surgery, there is no reduction of AMH.
Yes.
Another concern actually in all endometriosis is the recurrence. So what is your strategy to reduce the recurrence when you are doing the surgery? Everybody can share their practice.
The right person should do it.
Yes, that is one.
And maximum excision of the cyst, not fulguration, excision of the cyst is must.
Yeah, so there is enough data that when you are doing incomplete surgery, recurrence rate are very high. So you have to do excision as far as possible. But there is a question here that when you are removing the large endometrioma, you are losing a lot of tissue. With normal tissue, Graafian follicles are going, so AMH. So one should not be very enthusiastic in removing in spite of losing the normal tissue. So you have to really balance, and there is something called partial C is again a concern in these cases when you are removing large endometrioma, especially near hilum. So there is a technique which is called combination technique, where you are removing large portion of the endometrioma and fulgurating the hilum to reduce the chances of bleeding, as well as so you can devise, you can learn the technique to reduce the chances of recurrence. But certainly cystectomy is the answer. A thorough cystectomy will increase the chances of conception.
Yes.
Any other comment on surgery, or we can move? These are
One question.
Yeah, these are some of the guidelines. Dr. Roya, you wanted to say something?
Yes, sir. One question. Most of the literature is showing about the 3-stage procedure. I just wanted you to tell us about that, sir. And are you believing in that? Because there is a Cochrane meta-analysis which is showing the first step is the incision and drainage, followed by 3 months electric agonist, followed by the laser ablation. What do you think about this? Because the literature says about the Cochrane meta-analysis.
No, I think the consensus and the guidelines are very clear. When you are putting a scope, you have to do the thorough clearance of what you call the pelvis. It is a reductive surgery, so you have to be careful in reducing the maximum bulk of disease in first go. First surgery is always a best surgery in endometriosis. So you should not do first the drainage and then coagulation and then coming back to the medicine and then again doing the surgery. So that idea is not justified. That is not recommended. Surveen, can you move further?
Question 4.
Surveen, can you move further? Next. Yeah. So now this patient has undergone the surgery. What is the next step? You have cleared the pelvis. You have removed large endometrioma. Will anybody give the suppressive treatment, or will directly go for IUI or IVF? What is practice. Dr. Pratap?
Since you've cleared the lesion very well and then there's nothing left behind there, I would directly do IVF. But if I find the surgery done by experts and then it's completely frozen pelvis and I've tried to remove as much as possible, that means I left behind something. In those cases, I would suppress it for 3 months analogs, once a month, and then do the IVF. But my first choice is to just directly do because we have cleared the ovarian endometrioma.
How do you decide that you are going for IUI or IVF after
Not IUI. I think they directly take
IVF.
IVF only in this case.
So everybody will be going for IVF in this case?
No, I don't agree. If the tubes are fine, if the endometrioma, the cyst has removed and the pelvis looks fine, I think she's married for 4 years. She's a young person with good AMH. I think we should do IUIs, not ask her to try on her own. Do IUIs, and maybe after 2 cycles, I would go for.
Yeah, I think we discussed this earlier. 2 cycles should be fine.
Yeah. So no, basically it depends on the post-operative findings. If you have really cleared very nicely and tubo-ovarian relationship you are able to maintain. The literature says and recommendation says in all cases of grade 3 and grade 4 endometriosis. C is grade 3 endometriosis or grade 4 endometriosis, depending on the adhesions. So recommendations are directly go for IVF in grade 3, grade 4, but it may be an individual choice. If you are really satisfied with your surgery and tubo-ovarian relationship is maintained, then you may go for IUI. Otherwise, directly go for IVF.
Can I ask a question?
Yes, Dr. Sonia.
See, I'm asking everybody, are there any studies which tell us that what is the rate of recurrence after you wait for 1 or 2 cycles of IUI and then take them up for IVF?
Yes, you're right.
Because in our practice, whatever we find is endoscopic surgeons are doing this. They are actually allowing the patients to go in for either expectant management or IUI, and then at the end of it they come up with more cysts, and then we have to do IVF. That is my experience. So I really feel but Amit, you may not be doing expectant, but the endoscopic surgeons are doing expectant management also. Try on their own and then do it. Then the recurrence is very high. So I need to ask, how much is the recurrence in these patients?
20.
No idea.
Up to 20%.
Up to
20%. There's a wide range, madam. From 2 to 20% is literature.
How many months?
Recurrence actually depends upon the competence of the surgeon.
Yes. Not only that, Surveen, this disease is so tricky, you don't know. It may be a very, very good surgeon, yet it happens, it comes back. And I am very wary of it. I would agree with Dr. Pratap. I would go in for IVF immediately without I would not do an IUI at all.
And the least recurrence means a very good loss of ovarian cell.
Yes.
Actually, one has seen so many patients coming with recurrence from endoscopic surgeons who haven't sent them in time and low AMH. They come with recurrence and low AMH and you don't know what to do with them.
Yes.
I think all experts sitting here, they are very, very clear in their mind. Post-surgery, you have to go for IVF.
Yes.
Number 1. Number 2, there is no role of expectant management in such type of cases. Number 2, and even if you are planning IUI, it should not be more than 2 cycles. As far as the recurrence rates are concerned, they depend on the surgeon. Second, the stage of disease, at what stage you are operating. If you are operating at grade 4 stage, the chances of recurrence will be higher. Whatever you do, whatever good surgery you have done. So recurrence rate are dependent on the surgeon first surgery as well as on the the stage of disease. But within 2 cycles, the recurrence rate are not very, very high. But if you wait for 6 months, 1 year, certainly your patient is going to have recurrence. That is my experience over here. So we move on to the next question.
So the 4th case which Dr. Kuldeep and I have for you The fourth case which Dr. Pradeep and I have for you is a 28-year-old woman, married for 5 years, trying to conceive with a normal male factor, operated for endometriosis 2 years back, endometrioma removed from the right ovary. After that, 4 IUIs with gonadotrophins. Now AMH2, antral follicle 5+7. Recent USG shows a bilateral endometrioma of 1 into 1.5 centimeters on the left and 3.5 into 3 centimeters on the right. How would you manage her? Would the presence of the endometriosis affect IVF cycle results by impacting quality of the oocyte, embryo, endometrium, and pregnancy rates? What impact can surgery have on the outcome of IVF? So, Kunju, how would you manage her?
Yeah, here there is no doubt about regarding the decision. We have to straight away counsel her for IVF, and no question of any medical management or IUI in this particular situation. And the
anybody, Kunjumuddin, anybody in the panel for repeat surgery?
No.
Oh, no.
Okay, so that is one consensus coming out from the panel, no repeat surgery in such type of cases, because you are seeing a 3 centimeter endometrioma, and many of the patients, they again get the scopy done, and in that bargain, again you are losing time as well as AMH, and the prognosis becomes worse. So no recurrent, in recurrent endometriosis, if the patient wants a child, there is not much place until unless patient is having severe pain.
Correct. So only if she's symptomatic or your endometriosis is going to affect your oocyte retrieval, then only you touch it.
Yes.
Correct.
So now this is something we'd like your experience on. That have you found endometriosis affecting the quality of oocyte, embryo, and pregnancy rates? Because this is controversial as far as literature is concerned.
It is affecting.
Yes, it does affect.
It is affecting. So it is necessary to do the IVF treatment.
But ultimately, the pregnancy rate won't be that much significantly different.
So you find the pregnancy rate is the same. Do you find that there is a difference in the number of oocytes retrieved in such a patient?
Yeah, definitely. Oocyte number will come down.
And quality of eggs retrieved, oocytes retrieved?
Yeah, the fertilization rates, it seems to come down, but the quality of embryos and the pregnancy rate seems to be comparable.
Dr. Sonia, are you there? No. Dr. Pratap, what is your experience?
Yeah, I think pathophysiologically, we always expect oocytes to be of less activity because of the oxidative stress. But I think overall, the pregnancy rates are not that dramatically low because embryos do not seem to be affected. The number of oocytes may be less, but overall pregnancy rate, there's not much of difference.
Amit, anything different from this?
If endometriosis is combined with adenomyosis, then I think, of course, it affects the implantation rate.
Yes.
But by far and large, if it is going to be only endometriosis, I do see a decrease in the number for sure. And in my personal opinion, I think the embryo quality also is reduced.
100%.
So what about the pregnancy rate?
Yeah, so it is on the lower side.
It is on the lower side. It is on the lower side, so be.
So there is a lot of controversial literature on this. That's why there are papers which say no effect. There are papers which say there is a lot of effect.
Can I say one more?
Yes, you were not there when I was asking you.
I was just running. There is a very large data from SART, more than 3 lakh cases that they have assessed. And if endometriosis is alone, just the only cause, then there is no impact on the outcome of ART.
Yes.
But if it is with other things like tubal factor or male infertility or anything else, then yes, the pregnancy rate and the quality of oocytes is affected. That is very interesting. I mean, that is why the thing is so confusing. And now, ever since I saw that, we have started analyzing it on that aspect ourselves, and we do find that there is a truth in it. If it is only endometriosis, then there is no impact. But if it is associated with other things, yes, it is affected.
Yeah, and that is what this paper is also saying. This 22,000 women, 2017 Comodaran and the systemic review, both of them say the same thing, that the pregnancy rate is not affected.
One more comment. Actually, I have studied the blastulation rate. Blastocysts
all the literature.
are slightly low in endometriosis when you compare to the other population. But by and large, as everybody has said, that if you are getting a single blastocyst, good blastocyst, the pregnancy rates are almost similar. So
Can
that
I
is,
just add something? Because
yeah.
endometriosis is is again related to the Hox gene, and we know that women who have got endometriosis have disturbed Hox 9 and 11 genes,
Especially
and
adenomyoma.
I think Dr. Rosa Roati may put more because being a scientist she would know, but it does affect Hox genes, and these
Yes.
are connected to implantation rates, and we find that people with severe endometriosis have disturbed Hox 9 and 11 genes, indirectly giving you poor implantation
Yes.
rate.
Implantation fail because the inflammation which is there in adenomyosis and endometriosis, it will alter the gene, which is a key gene in the implantation. And therefore, this causes the failed implantation and increase the rate of the miscarriages and abortion.
Correct.
That is the reason that it is important to give a pre-IVF treatment. Pre-IVF treatment with the suppression, maybe 3 months LHRH agonist is necessary.
Yeah, so what we would now want to do is to do IVF, freeze the embryos, then maybe put the patient on GnRH depots and then transfer the embryos.
That is in
That's
adenomyosis.
what I do generally. I do the fertility preservation and then do the.
Correct, correct.
Or if it's a very big endometrioma, then I remove it. Do fertility preservation, remove it. If it's 4-5 this thing, then I remove
Dr.
it.
Pratap, what is your practice? Whether you are freezing in all cases of endometriosis?
Yeah, I think in all endometriosis patients, we are finding once you remove the oocyte, get the embryo, you freeze it, then you do the the FETs. They are better than direct transfers.
And even in the stimulation protocols, I prefer the long stimulation so that the ovaries are well suppressed rather than going for the antagonist.
So that was my one of my questions. So let's go on to that question on what protocols are we using which are in clinical practice. So Amit, we can start with you. How long a long protocol do you use?
Yeah, so I prefer going for the long protocol. Either the GnRH agonist long protocol, or if sometimes you find that the endometriosis is quite severe, I would want to give 3 cycles of GnRH depot and then go for ovarian stimulation. You get much better quality. I think the GnRH depot not only suppresses, but also I think it works on the immunomodulation and decreases the inflammatory reaction, may also decrease some amount of adenomyosis that is there. So it really works well on all those fronts.
Yes.
Dr. Pratap, what is your, how do you?
Yeah, I think we just discussed that because in case the surgery has been well done, then I just do antagonist cycle as such, because I know the AMH is borderline in these kind of patients. But if I find the surgery was not very efficiently done, then I think I would give 3 doses of GnRH analog monthly, then take them up for IVF. And that would be a better.
Okay, and Kunju, what is your take on it?
Yeah, I generally do antagonist cycle for these patients, retrieve the oocytes, make embryos, preferably the blastocysts, then give 3 doses of agonist suppression, then plan for frozen embryo transfer cycle.
Okay, what have we? I just like the experience of everybody that post surgery, have you seen an improvement in? Do you feel that the oocytes are better, perfectly normal compared to having an endometrioma there, or there is no difference?
Yes, this question is not there.
So does the surgery make a difference to our cycles? Is what the question is. To the implantation rate, to the fertilization rate, to the quality of oocytes? Is the surgery having?
I think it will help, but the fallout is that your AMH will also drop. So it's both ways that you have to look at.
So post surgery, do we always see a drop Or are there certain cases in which you predict a drop? Dr. Pratap, what is your take?
I know I published this data also, my own cases. It looks like it goes down a little bit for a few months, and after about 6 months, it's all back to normal. So I think it's just a transient fall, and if you find the dissection is done very well, there's not much of reduction in image. In fact, our team published it from Manipal. There's not much of difference.
Amit, what about you?
Yeah, I find that the AMH will definitely drop, although I don't routinely do AMH for all my post-operative patients, because that is not going to change my treatment for them. I've already decided what the treatment protocol is, do the surgery, and then take her up for the IVF. So by just doing the AMH, maybe I will just increase the patient's anxiety level. So normally I don't repeat the AMH. But I do a pre-operative AMH because that tells the patient and me also where she stands as far as the reserve is concerned.
Kunju, what about you?
Immediately after the surgery, if the patient goes and do AMH, we used to see the AMHs come down, and like Pratap sir has told, it used to come back to the normal level. If the surgery was completely done, it will come back to the normal level within next 4 to 6 cycles. But if the surgery was done with a lot of dissection of ovarian tissue, definitely AMH will not come back. Especially a lot of cauterization means gone. It is gone.
Yeah. Roya, what about you? What is your take on that?
The same. The AMH will be always less after the surgery. That is the main concern. That is.
So this patient was taken for IVF without surgery. What is the risk of not operating on the endometrioma? And we've discussed the second question, the preferred protocol. So what is the risk of leaving it there? We start with Roya. What do you feel?
Yeah. There is also possibility that maybe the accessibility is less to the follicles. Maybe also before IVF, the cyst will get torsion will be there, or maybe ruptured. So these are the possibilities. During the counseling, we have to inform the patient. But as an expert ART specialist, normally we can get access to the follicle. Sometimes we have to go through it and then have to again wash the needle. So these are the things which we have to be prepared for that.
Kunju, what do you feel? If you punctured a follicle, what is your protocol?
Yeah. If we puncture the follicle, we remove the needle, wash the needle again, or we change the needle, wash the needle with the oocyte medium, culture medium, and then reuse it. And we will inform the laboratory that previous tubing has been mixed with the endometriotic fluid, and they will try to keep that separately.
Any
and other chance of getting infection also if we accidentally prick it. So we have to give clear cut the antibiotic coverage as it is notorious for infection.
Sir, Dr. Pratap, what else?
Yeah, I think the number one rule is to avoid puncturing the cyst. You somehow get these oocytes without entering the cyst. But as Dr. Roya said, sometimes you have to go through the cyst and then you'll always find chocolate material. Then you have to remove the needle, wash the needle, and tell the embryologist that the oocytes are from that nearby cyst, because these oocytes which are next to the cyst are usually having a lot of oxidative stress. So I always tell my embryologist, just keep it aside, keep this embryo somewhere else, and don't give that as a first shot. So I know these embryos are not doing well. So I think first of all, number one is don't enter the cyst. If you have to enter, then you remove, clear the needle, and proceed.
What else, sir, do you feel is the risk of conservative management?
No, in this case, I think this is a very small cyst. You don't have to worry about it.
You don't have to worry.
Go ahead with the IVF and then hope for the pregnancy.
Yes.
Amit, what is your take?
I agree with Dr. Pratap. I think this cyst is quite small. There is no need to do a laparoscopy. Straight go for IVF. But as I said, I would do a long protocol. Maybe I would freeze and then transfer. But that depends on the quality of the embryo.
Okay. Amit, you have given the long protocol, then what you are looking for the benefit of freezing, because you have already
So if I'm doing a long protocol, I would definitely want to transfer. If I've done an antagonist protocol, because sometimes the patient doesn't want to wait or whatever, then I would definitely want to freeze. And if she's accompanied with adenomyosis, for sure I would not do the transfer. I would give her GnRH depot and then transfer.
Yeah. Yeah, so basically, when you are using long protocol, you are suppressing, and then you can do the suppress transfer. Otherwise, when you are using the antagonist, it is better to freeze and then suppress and
Correct.
then transfer.
Correct.
So we have already gone through the lot of discussion, and we have already finishing the time. We have exceeded, but this is one case which I would like to discuss in short. 27-year-old girl with adenomyoma, 14-week size uterus, uh, having dysmenorrhea. AMH is 3.6 nanogram per ml, male factor normal, and she is having infertility of 4 years. What is your management? Everyone has to give their opinion because this is a very tricky question. So I am sure that there will be lot of and Kunju, then Dr. Sonia also joined. So adenomyosis with normal AMH, how do you proceed in these
Yeah,
patients?
even the adenomyosis, the AMH is normal. It can affect the reproductive outcome very badly, mainly because of the defective uterine contractions, the increased uterine cavity size. So the implantation will be very less in cases where there is adenomyosis if it is not being treated and then do the fertility treatment. So generally, we used to get a lot of cases for laparoscopies, and we generally do a lot of laparoscopies for adenomyosis. And we make sure that we'll not do so many cases on a particular day. And if it is focal adenomyoma, it is not that difficult. We can do the adenomyoma excision. But if we are going with the wedge resection, should be very careful, and we should not hesitate to open and suture the myoma bed.
Answer the uterus.
So you are going for surgery and
We can very well do it.
that is what you are
Yes, sir.
saying.
Yes, sir.
You are going for surgery in adenomyosis and then planning the further treatment. That is what you
Yeah,
are saying.
exactly.
Okay.
If the AMH is normal, we can very well take up the patient for surgery, treat it properly, then do it. If the ovarian reserve is low, rather we can retrieve the oocytes, keep the embryos ready without wasting time, because after the surgery we have to wait for quite a long time before going with further treatments.
Yeah, Dr.
So if
Roya?
the reserve is less,
Yes, sir.
retrieve the oocytes, preserve the embryos, then do the transfer after the surgery.
Yes, can I say this answer, sir?
Yeah,
I have seen Dr. Kuldeep Jain review, excellent review you have done, sir, where the role of the conservative procedure, like high intensity ultrasound thermocoagulation, it decreases the size and the volume, and the spontaneous conception is being reported. In that review, you have also mentioned, because of this so much of review, you have mentioned that literature where there is a large study which is done by Wisney, where he has seen the uterine artery embolization. Also, there is also report that clinical pregnancy is reported with spontaneous conception with only LHRH agonist for 3 to 6 cycle. These are the modalities of treatment. Even the progestins and the levonorgestrel also it's being used for as an intrauterine contraceptive device to reduce the pain, to reduce the bleeding, to reduce the volume and the size of the adenomyoma. And then after all these things, patient has got a chance for clinical pregnancy. And if things does not happen, then the best would be a LHRH agonist and then frozen embryo with the HRT cycle, best for these patients with the adenomyosis. That is what in that review
Dr. Sonia. Yeah.
If it is focal, then just as Kunju says, it is easy to do that removal. You'd excise it. But if it is diffuse, What
It's
option do you
difficult.
have except giving a GnRH agonist for a long time? Or as Dr. Rosa says, now they're also considering the IUDs, the even the danazole IUD is now being used. So basically, something or the long LNG IUD, all these procedures to decrease the size of the adenomyosis, especially in this case where it is a 14-week size uterus, you have to decrease it before you attempt anything in this particular case. So therefore, yes, something will have to be given to this girl for a long time before we even start to think of IVF. Of course, as
Doctor.
everybody has said, you make the embryos first and keep them aside and then start doing this, because yes, the ovarian reserve is always to be considered, but yes, the adenomyosis has to be treated.
Dr. Pratap.
Yeah, I think that was quite a good discussion by others. I would just differentiate into focal adenomyoma,
Yeah.
adenomyosis, or is it general, as Dr. Sonia said. If it's focal, I would remove and proceed. If it's not focal, I would give 3 cycles of GnRH analog, even 6 months. But as I said, I would remove the oocyte and preserve it. And then when I swing the uterus little later by analog, and I put it back later. I think the number one should be to reduce the uterus, either surgically or non-surgically, depending on the local or focal or whatever it is. And then proceed with embryo cryopreservation, and then proceed later.
Dr. Amit.
Absolutely.
Amit, are you there?
I have a question for everybody. If it is a diffuse adenomyosis, what uterus size would you transfer and what uterus size you would not transfer? Where would you stop?
I would answer that first because I had some good experiences. I did get pregnancies when it's around 12 week size. And it's nothing, if it's more than 12 to 14 week size, when you give analogs for about 3 to 6 months, it reduces by around 20 to 30%, not beyond that. And I think it will still be around 12 weeks. It never goes lower than that. In fact, doctor patients, I did that. She got actually good pregnancy in the first cycle itself. So like that, there are many more good stories.
Yeah, I would like to share. I would like to share one my experience. 26 week of adenomyosis diffuse. I did the surgery. After surgery, the size was around 16 to 18 week size. We gave the GnRH analog in that patient.
6 cycles. 6
Yeah,
cycles.
3. I gave for 3 and then transferred the embryos. She conceived, carried on till 18 week, and then had a miscarriage. So the story is, whatever you do in these cases, the chances of miscarriage, they may conceive, but the miscarriage rates are very high if the uterine size is more than 12 weeks. Even in the smaller uterus, when you are doing the transfer, the conception rate may be improved by combining. That is what literature everybody has highlighted. Then when you are in adenomyosis, conception rate are low. When you are combining surgery, fertility preservation, and
So I would say 12 weeks would be the cutoff for all of us.
Yeah, correct.
One more thing for the audience. How long would you give a GnRH agonist to reduce the size? 3 months, 6 months, 4 months? Where would you stop that? Okay.
I would give for 3 months and assess the response in the ultrasound. If I find a response to that by at least by around 15% of the
You can give it for 6 months. You can give it for 6 months.
Yes.
If you find a response, you can give
combined
it
thing
for
with
6 months.
analogs and in the intrauterine device.
Yes.
No, I think Sonia is right. I would agree for 6 months.
6 months. And
one more thing. I would say that we must look at the junctional zone. If the endometrium is okay, I mean, over there you don't find any adenomyosis, then the chances of implantation are much better. And then those are the ones whom you can actually take on for, just as Dr. Pratap says, 12 week size.
But if the junctional zone is also gone along with the size of the uterus, then I think
Then
we'll have to wait longer.
Yeah.
Yeah.
Amit, any take on this?
The
How long?
junctional zone is always disturbed in adenomyosis, whether it is
Not always,
small.
not always, Dr. Kuldeep, not always. Not
I think
always.
3 months for sure I would give
Yes.
her. Then based on that, as Dr. Pratap said, I would review her and then see whether I
Yes.
need to give more.
Correct.
Also, I think it is important to put them on calcium supplements at this time if you are going to
Correct.
put them on GnRH.
Back therapy.
Yeah.
So,
For me.
one more question. Do you do the volume of the uterus for reduction, or is it the dimension of the uterus which is done? With 3D, we can do the volume also.
Volume is a volume.
Frankly, if it's a focal adenomyoma, I would go for
Yes, exactly.
resection. In a diffuse case, it becomes rather very difficult to do the surgery.
Now, I have a very simple suggestion. I have simplified my protocol because if you look at the posterior wall, there's always that's larger than the anterior wall. I measure the posterior wall much more meticulously than the anterior wall. Of course, I measure both walls. If I find a reduction in the posterior wall, that's a very good response.
See, mapping is very important part of adenomyomectomy surgery. If you have mapped the uterus very well with your 3D and other thing, you can reconstruct the uterus in a better way, and you should always leave at least 1 centimeter on both sides to reduce the chances of the rupture as well as what you call the increase in chances of pregnancy rate. So always,
I agree.
always leave 1 centimeter.
Can I just continue my answer?
Yeah.
If you look at the archimyometrum of adenomyosis, it is always the posterior wall because it's a loosened area in the posterior wall. So when I find the response is good, I find the posterior wall shrinks. I think that's a very simple clue. Rather than, of course, 12 weeks is the cutoff, but just start observing in your clinical practice. You'll really find some change in the posterior wall. And I think this is a good observation which I've made. Nobody has published this data, but.
I think we had very good discussion during this, and we have already suited the time. But there are few cases, few questions from audience. I will like to take them up. But before that, we had a lot of take-home messages from our discussion, and I hope they were very useful to our viewers. There is one question, Kunjumuddin, you can answer. You have already answered this, but they are not able to see. Is there any increase in ectopic pregnancy with ovulation induction and endometriosis? Kunjumuddin?
Yeah, actually, there is no statistics like that. This endometriosis will increase the incidence of ectopic. But per se, because of this mechanical issues of adhesions, there can be chance because the pad may be there over the uterotubal junction, etc. So mechanically, there can be just because of adhesions, not because of endometriosis.
Okay, the next question, actually it was the 6th case of our discussion. So I am taking up this case. This question.
Should I put up the slides?
No, we will take the question directly. How to manage young unmarried girl with endometrioma and what counseling should be given? Dr. Pratap, you can take.
Yeah, I think in a young girl, unmarried girl, if the size is less than 4 centimeters, we should avoid surgery. Even whatever size it is, I will avoid surgery at the beginning. I have good medical management to diagnose and see how it works because it works wonder for a young girl. But I always feel if they're nearing the marriageable age, you somehow push this to marriageable age and then remove it later because, it's always a stigma that somebody has an operation before marriage. So I think that's what I think. But if it's a large cyst, I think you take a decision on removal. But up to 4 centimeters, I think we should just wait.
What medical?
I give Dino just 2 milligrams per day continuously for about 6 months, 12 months, and even beyond. I've been for 2 years. It is quite very successful because, of course, it never goes. The endometriosis never goes. It just reduces symptomatically. She's better. But once she's married, I think then you remove.
Yeah.
Anyone for GNR channel analog in young girls?
No. You cannot give that for more than 6 months because it causes osteopenia and osteoporosis. Not porosis, but
Correct.
osteopenia.
Correct.
No, no, no.
One usually gives an add-back therapy. In case intractable pain and you're giving a GnRH analog, you can give add-back therapy. It does not hamper the
Yeah,
treatment.
so before moving on to surgery, even if your oral medication is failing, that is one indication that GnRH analog may be combined. Actually, you can start with GnRH analog and then switch on to the oral. The disease-free interval and pain-free interval can be increased. So that is one observation coming from one very large study on adolescent endometriosis. So I think there is no more question from the audience. So I will like to sum up this discussion. We had a very on behalf of our my co-moderator Surveen. I will like to thank all panelists, all experts. It was a really wonderful discussion, and that is what I wanted. That all questions should have a lot of discussion, inputs, personal inputs, as well as the literature, and we have reached to some conclusion. Surveen, you will like to sum up what messages has gone through the discussion, 1, 2, 3, 4, and then we can wind up.
So basically, no pre-operative therapy, no medical therapy for infertility patients. We are going to operate if it is a single endometrioma. We will remove the endometrioma, test the tubes. In mild to minimal, we will give an IUI trial with gonadotrophins, maybe for 2 cycles, maybe 3 cycles, depending upon the response. We post-operative therapy may be given if surgery is incomplete, you feel surgery is incomplete, then you give a post-operative therapy and then take her up for IVF if it is a grade stage 3 or 4 endometriosis. In mild to minimal, we will not take her up for IVF directly, but we will give her an IUI. In adenomyosis, we can operate on a focal adenomyoma and subsequently take her up. There is a very strong consensus that we remove the oocytes, freeze them, and then do the surgery, then suppress and take her on for a frozen embryo transfer. In a young girl, it is important to not operate unless it is absolutely essential. You can put her on medical therapy. Dynogest is one of the good drugs to give her and can be given long term. Intractable pain, you can give a GnRH analog with a add-back therapy, but it is preferable to avoid it. Anything else?
Yeah, I think you have completed. Yeah, you have completed. The only thing is surgery. If you are putting a scope, you should think 100 times whether it is going to help or it is going to. So do no harm by doing surgery. You have to be very careful, and counseling before surgery is very important. What you are expecting and how you are going to manage. Recurrent endometriosis, again, patient is for infertility. Operative procedure is not advised. You can directly go on to the IVF, as well as when you are having an endometrioma, there is no need to remove endometrioma. You can directly go ahead until unless it is coming in your way, very large endometrioma, patient is having pain. So there are few indications of surgery before IVF, but not always. Most of us are preferring to go directly for IVF, and literature is also supporting that there is no benefit. We are not increasing the chances of conception by doing surgery and then going for IVF. There is a very large literature, large data, which have compared surgery and no surgery, and pregnancy rates remain same. So these are some of the highlights of this discussion. I take this opportunity to thank all my panelists. They have done a wonderful job. They deserve a round of applause from all of us. And of course, Indian Fertility Society has been doing a great job. So thank Dr. Sudha and Dr. Neena Malhotra for giving us this opportunity. And Bharat Serum Thank you very much for sponsoring this program. Finally, the team Science Integra session and Bruno, thank you very much for a smooth conduct. Thank you very much.
Thank you so much to IFS and the moderators who have excellently moderated and got out the best of salient features from all our panelists. Thank you
so
Thank you
much,
very
all
much.
of you. Pleasure
Thank
meeting
you.
everybody there. We should
I would
meet
just kind of
not on the
interrupt
Thank
stage.
you.
We
It's a
should meet
pleasure.
personally.
Before we wind up, I would like to share an information that this panel has been really taken up very well. Thank you once again. Just sharing that there have been over close to 2,000 viewers, 1958 viewers precisely, who have
Very
viewed
good.
this from Algeria, Cameroon,
Wow.
Myanmar, Philippines, Sri Lanka, Nepal, south of France, Ukraine, and Nairobi. So
Wow.
thank you all very much for sharing the
Very
vast wealth of knowledge.
Thank
And
you
I would
very
just,
Very good.
before we wind up, with the next panel is on the next Thursday, which is on endometriosis and pain. And again, we go on subsequently with the third and the fourth Thursdays. Thank you very much once again.
Thank you very much.
Bye-bye.
Thank you all.
Thank you.
Bye.
Bye bye.
Thank you, everyone.
All on board.